Welcome to AETCM, the Emergency Medicine Channel.
Yes.
Presenting the case of a 22-year-old female who came to ER with complaints of sudden acute onset facial deviation to left side since last 2 hours. On initial 10-second assessment, the patient was conscious oriented. She was talking in full complete sentences and the airway was patent. There was a mild pooling of secretions in the right vestibule and there was no gurgling sounds or stridor. Breathing wise, the saturation was 99% in room air, the chest was clear and respiratory rate of 18 per minute. And the circulation wise, the BP was 120 bar 76 millimeters of mercury with pulse rate of 72 per minute and a capillary refill time of 2 seconds. And disability, the GCS was E4, V5, and M6. Pupils were equally and reactive to light with a size of 2 mm. And the exposure wise, the temperature was 98.2 degree Fahrenheit and the GRBS was 97 milligram per deciliter. And there was no presence of any rashes or external injuries. And as adjuncts to the primary survey, we had also taken a point of care. CBCRP point of care was taken, showing a total counts of 6,000 with a HB of 12.1 and a CRP of 2. And
You took the CBCRP?
the patient came with...
They came with the facial deviation, right?
Yes, sir.
So why all of a sudden you decided you will take CBCRP point of care?
So basically, this patient, we just wanted to rule out any infective causes also there for this patient or not. So just to
No, your first facial deviation, your first DD
is always a stroke.
is a stroke, right?
Yes, sir.
Yeah. So my question is why you all of a sudden jumped to CBCRP?
Yeah.
So only thing is either human facial palsy or element facial palsy.
Yes.
Okay.
Yeah. And following which we had taken...
Anyway, it was normal.
Yeah, it was normal. Yeah. And we had taken a sample history. It was a 22-year-old female with no known comorphs who came to ER with complaints of facial deviation to left since the last 2 hours, along with drooling of saliva from the right vestibule since the last 2 hours. The patient also complains of mild difficulty in closing the right eye since the last 2 hours. The patient does not give any history of any ringing sensation from the ears or any difficulty in hearing. No history of any increased tear flow from the eye or no history of any increased hearing.
You didn't tell about the detailed thing, like
the
odipara.
Yeah. So the onset was acute.
Onset was what was she doing at that point of time?
Yeah. So she was actually sitting in her room and she was while eating. So during the eating time, she suddenly observed that she developed a facial deviation. The bystanders had observed that she developed a facial deviation towards the left. And following which there was presence of drooling of saliva from the right side of the mouth, from through the vestibule. And also she found difficulty to close the eyelid of the right eyelid. So this was the main complaints with which she presented to the ER. The onset was acute and the intensity, it was moderate intensity in nature. And there was no aggravating or leaving factors. And the patient was not associated with any weakness of limbs, or there was no association.
How did it progress? Onset, duration, intensity. Yeah. How did it progress?
It was continuously. It was not like increasing in the intensity, or it was not progressing. The progression was.
So all of a sudden, she developed this thing.
Yes.
Facial weakness.
Weakness. Yes.
Which has been constant like that for the last
2 hours. 2 hours. Yes, sir.
Associated with some drooling of this thing and inability to
blink
eyes.
Yes.
Okay.
And these were there was associated symptoms were mainly the difficulty to close the eye, and there was no history of any ringing sensation from the ears, difficulty in hearing, or there was no history of any like increased voice hearing of increased intensity of sound or hyperacusis, or there was no presence of any increased tears from the right eye. And there was no presence of any itching or rashes along the face or the mouth or on the ear region, and there was no presence of any associated fever cough associated with it. And the patient does not also give any history of any headache, vomiting. He does not give any history of blurring of vision, and also any history of urinary or fecal incontinence or presence of any seizures. And so these are the
No limb weakness.
no limb weakness.
No history of trauma.
No history of traumas. No history of trauma to the eye. No history of trauma. No head. No history of any head traumas. So this was the history wise, and the allergic history. The patient was not allergic to any medications. Medication history. The patient did not have any regular medications, and past history. There was no significant past history for this patient. And the last meal was taken 2 hours back.
Past history means what? What significant means what?
So the patient did not have any comorbs, so he did not have any history of
what comorbs are you basically?
Yeah, so usually in patients of acute onset facial deviation, we should always ask for the comorbs, maybe presence of diabetes mellitus, type 2 diabetes, or hypertension, or dyslipidemia in such patients. History of any previous viral infections. So
How old is she?
22 years. Yeah, so history
Stroke is very unlikely.
but history of a previous viral infection, history of a recent viral fever is one of the significant history which we always ask in such patients.
Chickenpox.
Or even herpes simplex, herpes simplex or herpes zoster infections. So
even Ramsay-Hunt
syndrome. And so these are the usual histories which are involved in the.
No other neurological issues also.
Yes, sir. The patient did not have any neurological deficits even at birth. There was no presence, and so these were the no history of any facial surgeries too. So we should ask about the surgical history too. Even in patients of if patient had a recent ear surgery, a history of a previous CSOM or a CSOM surgery requiring a exploration or a mastectomy, such patients can also present with acute onset facial weakness. Another possibility is that in patients with a wisdom tooth removal. So in such patients, the inferior alveolar nerve can get affected. In such patients also, they acutely present with mild facial deviation, but they gradually get corrected with anti-inflammatory medications. So these are the relevant.
Any parotid gland enlargement?
No history of any parotid gland enlargement. And as far after this, we moved on to the examination. And
all other histories are.
Yes. And as part of the general examination, the patient was conscious, oriented. There was no presence of any pallor, icterus, or cyanosis.
So at the end of your history, your primary, as an emergency physician, your primary objective is to find out whether it is a UMN lesion or an LMN lesion. If it is a UMN lesion, it means it's a stroke, and immediately your management will change.
Yes.
If it is an LMN lesion, then you will have to find out what caused this LMN lesion.
Yes.
If it is a idiopathic facial nerve palsy, it's called Bell's palsy. Otherwise, you should find out what other things, other causes of Bell's palsy, whether it's Ramsay-Hunt syndrome or otitis media, or whether it is some history of previous trauma, or it could be some cholesteatoma, acute otitis externa, or if it is a parotid gland enlargement, which is compressing the facial nerve when it goes out of the stalamastoid foramen. Because you should know, if it is an LMN lesion, you should know the entire the course of the facial nerve. How is the course of the facial nerve?
So the facial nerve usually it originates from the pons.
So basically, in an examination, your priority should be to test the cranial nerves. Apart from the ruling out a UMN pathology, your priority should be, once you know it is an LMN facial palsy, do a detailed cranial nerve examination with focus mostly on the facial nerve, the trigeminal nerve, and the glossopharyngeal nerve, and the vestibulocochlear nerves. Yes. Okay.
So usually after this, we did
the course of the facial nerve.
So the facial nerve usually originates from the pons. So the pons, there is a presence of a facial nucleus, and there is also the associated superior salivatory nucleus. So as it goes downwards, it goes through the temporal bone. So before going to the temporal bone, it goes through the internal auditory meatus.
Yeah, it goes inside the internal auditory
meatus, and then after that it gives a branch of greater petrosal nerve. So there's a greater petrosal nerve which usually carries the secretomotor fibers to the lacrimal glands. So that is mainly for the lacrimation, and after that after that the nerve it goes into the geniculate ganglion. So it's mainly in the genu part of the in the facial canal. So as it goes through the facial canal, after going through the facial canal, it gives a branch of nerve to stapedius. So it gives to the stapedius muscle. If stapedius muscle is getting affected, the patient will present as hyperacusis. So even a small noise can hear with a high intensity for the patient. And then after that, the patient, another branch is a chorda tympani. So chorda tympani with the lingual nerve, it usually gives the supply to the anterior two-third of the tongue. So only the secretomotor
taste will be
taste, and also it also has an additional role for the secretomotor activity of the submandibular glands and submandibular and sublingual glands. So it also has a role in that. And then after going through, it goes through the stylomastoid foramen. And after passing from the stylomastoid foramen, it gives of 5 branches. Yes. So these 5 branches, it's like and the hand. So the 5 branches are, first one is a temporal, zygomatic, buccal, marginal mandibular, and cervical. So these 5 branches are given. These are the parts of the pathway of the facial nerve in LM. And this is how the course of the facial nerve occurs. And as part of the examination, after doing the general examination, there was no presence of any pallidus, cyanosis, clubbing, lymphedema, or pedal edema.
What about the sensory part of this thing?
Sensory part of the facial nerve is face is mainly handled by the trigeminal nerve.
Nerve. It's not facial nerve.
It's not facial nerve.
It's ophthalmic, maxillary, mandibular
nerve. So following which we had
and that geniculate ganglion which you mentioned was in the facial canal usually gets affected by the herpes zoster thing, and that's when we call it as Ramsay Hunt syndrome.
And so in part of the CNS examination, initially we looked for the power of the limbs. So as the power of the limbs was 5/5 in all 4 limbs, then we look for the cerebellar signs, the finger nose test, the finger test, and dyskinesia was absent.
So was there any problem?
No, cerebellar signs was normal.
CNS examination
central causes, there was no presence of any abnormality.
So you okay. So the upper part of the face, was it spared?
For this patient, it was not spared.
So it means it is
affected.
element.
Yes, it's affected.
Element facial palsy.
So this patient, after doing this, we did the cranial nerve examination. In cranial nerve examination, initially we did the one was the olfactory nerve. There was no issues for the smelling. It was fine for the patient. On the ophthalmic examination, the power was 6/6. The visual acuity was equal, 6/6, and normal for both eye. Then we looked for the third cranial nerve. There was no presence.
Other detailed things are there. You'd love to find out for each nerve what all things are specifically to be looked at.
Yes, and then look for the reflexes also. We look for corneal reflex and conjunctival reflex. Both those reflexes were normal for the individual. And following which we looked for the 5th trigeminal nerve. Trigeminal nerve, we look for the sensations.
You just skipped other cranial nerves because you're basically focusing into trigeminal and facial, right?
Yes.
Okay.
So trigeminal nerve, we look for in trigeminal nerve examination. Mainly, we look for the different sensations. So fine touch, crude touch, and also
basically trigeminal nerve has got both sensory as well as motor thing.
Yes.
So you'll have to first of all check the sensory thing, then motor.
So
sensory, how will you check?
Sensory, we usually check the initial fine touch, crude touch. Then we look for the position, the sense of the patient, proprioception. Proprioceptive fibers are there by the spinal nucleus.
So in this various ophthalmic, maxillary, mandibular area, you just with the cotton and also the neurotip, you just see if of pain everything is there or not.
Yes.
Okay.
And next, what we did was we had to check the after the sensation part, we should look for the reflexes. So reflexes is usually
Motor.
Yeah, motor is the motor. We look for the power of the muscle. Mainly involved is the first one is the temporalis.
Yeah.
Temporalis muscle.
People like that and ask to clench.
Yeah.
Okay.
So in the clenching time, there's the temporalis muscle prominence, and after that we look for the masseter muscles, and also we look for the lateral and medial pterygoids.
Yeah.
And
like this.
movement,
Either side.
medial movement and lateral movement.
Okay.
So these are the usually the how we test the fifth nerve.
Reflexes. Then
reflexes. We do the conjunctival reflex and corneal reflexes.
Okay.
It was both was normal, and we look the jaw reflex. Jaw reflex was also normal for this. There is no increase in the activity of the reflexes. Increased activity of jaw reflex will be present in like pseudobulbar palsy and can be increased. So then, following which we look for the seventh facial nerve examination. Facial nerve examination, we ask the patient to look up, so that we want to look up whether the presence of frowning, look upward look
motor,
posture,
you are looking for.
The wrinkling of the forehead is what we look for. So in this patient, there was no wrinkling of the forehead. So the upper part also was affected, which means that it's a element facial palsy. Because in UML,
so it's not in the brain. The lesion problem is not inside the brain.
Yes.
It is somewhere outside the brain.
Yes.
So the next question is, where outside the brain? Is it after, like, entering the facial canal, or is it after the facial canal, the lesion?
Yes.
Okay. If at all it was after the facial canal, normally ophthalmic maxillary mandible. The 5 branches of the facial nerve, only those things will be affected. If it is inside the facial canal, naturally, the other nerves, the nerve to stapedius, all those things, cauda tympani, all those things will be affected.
So in this patient, there was no affecting of any lacrimation. Lacrimation was fine. There was presence of pooling of saliva, but there was no presence of increased salivation as such. And for this patient, then we were able to, after doing this, we checked for the facial deviation in this patient. So in this patient had a facial deviation to the left, and then after that we examined the 8th nerve. So in 8th nerve we look for the hearing. So
the upper part of the face has got a bilateral innervation from the
both cortex.
Both cortex. So that is why the upper part is
in a UMN lesion.
In a UMN lesion.
Okay. So usually, if patient presents with a UMN facial nerve palsy, their forehead that wrinkling, it will be spared, and there will also be presence of this absence of ptosis, or like not ptosis, the inability to blink the eyelid.
Inability to
blink the eyelid, that will not be affected. So
is Bell's phenomenon normal?
Bell's phenomenon is a normal phenomenon, but in usual patients with facial nerve 11 facial palsy, they will not be able to completely close the eyelid. So in such individuals, they will be presenting with that Bell's phenomenon, that upward rolling of
upward normal. Otherwise, also normal patient also, if you try to close the thing, the eyeballs will roll up. So that's normal phenomenon.
So that can be visualized by the examiner. So that's why it's called as a Bell's phenomenon. And following which we had done the 8th cranial nerve examination. The hearing wise, it was normal. The Rinnes test and the Weber's test. There was no lateralization or everything was.
Then ear examination probably you would have done to look for all these cholesteatoma, acute otitis media, malignant otitis externa, all those things you would have already checked.
Yes, as here part of ear examination, we look for a tracheal tenderness or mastoid tenderness. Look for any presence of vesicles, and we looked for the tympanic membrane also. Tympanic membrane, it showed cone of light, and there was no presence of any perforations as such in the tympanic membrane. And following which, we had also done an oral examination for the patient. In the oral examination also, there was no presence of any vesicles or rashes in the patient.
That is seen in Ramsay Hunt.
Yes, in Ramsay Hunt, there will be presence of oral lesions. At the end, we came to a final
this thing, external examination.
Yeah.
Because you'll have to trace the entire thing. From the origin of the facial nerve, from the starting itself, you'll have to trace down. From the brain itself.
Yes.
From the brain itself, you'll have to trace down, and from the origin of the facial nerve, you'll have to trace down. And finally, when the facial nerve exits through the shallow muscle foramen, the parotid. When any tumors or anything of that sort is there. That is also clinically nothing was found.
Following which we look for the ninth nerve, the glossopharyngeal nerve. In the glossopharyngeal nerve also the taste sensation of the posterior part of tongue. It was also normal. And following which we had looked for the 12th cranial nerve, hypoglossal nerve. Hypoglossal nerve patients will present with tongue deviation. So we told the patient to protrude the tongue. There was no presence of any tongue deviation also for these patients. So following which we came to a diagnosis, provisional diagnosis that patient has an element facial palsy, not explained by any other cause. So we came to a diagnosis of an idiopathic facial nerve palsy, where most
Also
of the
called
Bell's
palsy.
Bell's palsy. And since the patient had come within 2 hours of presentation, the another like neurological part like had to be ruled out. So we asked for a MRI for this patient too.
Ideally, it's not indicated because
Indicated,
clinically it's clear-cut Bell's palsy.
Bell's palsy. And the MRI came to be normal for this patient. And following which we had discharge. After that we had.
So what is your plan from the ED? What is your plan?
Yeah, so part in the ED is mainly to identify the what is the actual acute presentation. So mainly
identify the differentiate between human element and then differentiate between other causes of Bell's palsy. Okay.
Then
so once it is proven as Bell's palsy, what will we give?
Yeah, so in actually in proven case of Bell's palsy, we should look for the we should give steroids. So steroids is the initial line of management, and the steroids must be given within 72 hours of presentation. So usually we give prednisone. Prednisone usually with a dose of 50 to 60 mg. So that can be given at a dose of for 10 days. So that is the usual dose which is given. And so this is the usual.
With that you can discharge the.
Which we can discharge the patient. But always make sure that even after 4 weeks, if the symptoms persist, then it requires a further neurological evaluation for such.
The other thing is delayed presentation of Ramsay-Hunt
syndrome.
If initially it may not be present, later on after 2-3 days again lesions may appear.
Yes.
So in that case, your diagnosis changes to Ramsay-Hunt. Yes. So immediately you will have to start on antivirals. Okay. So what antiviral will you start?
We start on now. We can start on Ganside.
No, in this case, you need not start. But if at all it turns out to be a Ramsay-Hunt,
we can start on Ganside. Ganside 1000 microgram. Or acyclovir also. Or acyclovir, alcyclovir also.
How much?
In valacyclovir, it's usually 1000. 1 gram TID. 1000 mg TID.
For how many days?
It's usually 5 days. So usually
acyclovir
800 mg 5 times
for 5 days.
For 5 days. So this is the usual medications given. So usually Bell's palsy, as part of the discussion, usually the pathophysiology is usually idiopathy. But it's always told that there are
there is one classification called House-Brackmann classification. The severity of this thing.
Yes. Yeah. So House-Brackmann classification.
That's okay.
Yeah.
You can just read.
Yeah.
Grade 1 to 6.
Yeah.
Grade 1 is normal, mild, moderate to severe, then severe and paralysis.
Yeah. Full paralysis.
Yeah.
So then regarding the blood test, there are no specific blood test as such, but there is always a propensity for in patients, young patients coming with 17-hour palsy, they have a propensity to have a like future hematological malignancy. So it's always told like in children, if it's there's also propensity because such as in CNS lymphoma, there's always a risk of CNS lymphoma in such patients. And in MRI, there can be presence of enhancement along the long segments along the facial nerve branches. It can be present in 57% of cases. Usually, the complications in case of Bell's palsy usually involves corneal drying because the eyelid will not be closing completely. So such patients will present with corneal abrasions and drying. So we give teardrops, and taping of the eyes treatment for such patients. That's and the loss of taste of anterior two-third of tongue when the chordate membrane is affected. That's other hyperacusis. Or then these are your incomplete recovery. So some patients even after the course of steroid, it will not get completely recovered. So then there can be a presence of an aberrant regeneration. So the regeneration of the nerve fiber it can lead to like crocodile tears, which is what like mainly while eating.
Yeah.
During the
Will
eating time,
lacrimate.
there will be increased lacrimation.
Lacrimation. The autonomic synkinesis.
Synkinesis.
Okay.
So that can also affect, and gustatory sweating can also. Facial innervation can also lead to a depression. So patient and social point of view. Management is always early corticosteroids within 72 hours, and then the eye care. Eye care is mainly involving the glasses or protective patches. So as I'm usually part of symptomatic approach to the Bell's palsy. In acute Bell's palsy, we should evaluate the eye closure initially. So if the eye closure is adequate, then eye protection is not needed. But if eye closure is inadequate, then we require the protective measures I mentioned before. Then we should look for the degree of the facial weakness. So the degree of facial weakness is usually classified by House-Blackman classification, mild or moderate facial weakness. As in grade 1 to 3, always requires an early treatment with the oral glucocorticoids, usually prednisolone 60 to 80 mg daily for 7 days. It's recommended. And in severe or complete facial weakness, as in House-Blackman grade 4 to 6, in such patients, the patient requires early treatment with oral glucocorticoids and prednisolone itself for a bit more longer duration, 10 days. And then adjuncts, we should add an adjunct also. If patient has a severe facial weakness, we give valacyclovir 1000 mg also for such patients, only in severe cases. And after follow-up evaluation,
even if it is not there, even if there is no
Ramsay Hunt, no evidence of Ramsay Hunt also, we give prophylactic
as per this House-Blackman
for severe grading. And in case of follow-up evaluation, in complete, then if after
the severe means how do they say severe?
Based on House-Blackman classification itself, grade 4 to grade 6.
The features should be there.
Eye closure and the degree of facial deviation. And the follow-up evaluation is if it's getting completely resolved, then it's fine. If it's an incomplete recovery, then we can give injection botulinum. So botulinum can be given.
That is not in ER, no? That is
further
in OPD.
Follow-up.
Neurological.
Yeah, and even after 4 weeks, if it's not improving, it requires neurological evaluation. This is the issue.
Anything more to add? Thank you.